So here we are. This is towards the end of week 7. Time has just flown and um, not much left to do. You all have all done we're going to talk about your discussion board here in a minute, in a little while. Um, but last big thing is the final. Um, Dr. Jones, do you want to start tonight? Doesn't matter. Okay, I'll just go on, and I have a few things that I was going to talk about. So let's just start. Um, like I said, we'll talk about the discussion board in a minute. So, reminders. You didn't have any assignment this week, so um, hopefully you've had some time to wade through the lectures. Your final exam opens next Wednesday, the 12th, at noon Eastern Standard Time, and closes next Friday, the 14th, at noon Eastern Standard Time. If you've not signed up, please go ahead and get signed up. Don't wait till the last minute. And I recommend that you look back at those instructions that I sent in week 2. It was a fairly lengthy um, thing about ProctorU with all of the tips and the bandwidth and all that. Maybe look through that again. Just make sure you've got everything um, set up as best as you can so you won't have any problems. I always seem to have problems with people who wait till the very last appointments, but that can't be helped. Hopefully, that will not be as big of an issue this time. I hope not. But if you're not signed up yet, please get signed up. You don't want to wait till the last minute. Um, I'm sorry, there have been week 7 and 8. I feel like they just kind of fell apart on me. Um, in week 7, once we finally got that lecture working, as someone pointed out, the audio on slides 15 and 16 were the same. It was the same audio, and I have no idea in the world how that could have happened. That just makes absolutely no sense. But the transcript for slide 16 is correct. So we apologize for that. We don't know what happened when they were formatting that. Um, but we didn't have enough time to get it redone. So just use the transcript for that. And then apparently in week 8, and I'm surprised this hasn't come up before, but in week 8, there were some tables, and I just posted an announcement today. They were in your 2-Sci book. And the page numbers gave are different than the page numbers that you apparently have in your ebooks. So I think that the issue is I'm working from a hard copy of the textbook, and you all are working from ebook. And so I'm gonna have to figure out a way to get that to get that taken care of for next time. But um, I posted in your ebook where those tables are, so you can find those. So I'm sorry about confusion. And like I said, I'm really surprised it hadn't come up until week 8. This is the first time anybody has ever told me that it's been different. So have you all noticed any discrepancies in page numbers? Those of you who are here?
There was one chapter, I'll be honest with you, but in another book, and I just it was just like I think it was like maybe said 25, but it was like 24 or something like that. You know what I'm saying? So I could have I found it easily, but so
Yeah,
um
I try to make sure that I put not only page numbers, but the section, what the section is about, so that if for some reason the page number is off, you can at least find that heading, that section. But I know it had to be because my 2-Sci book is a hard copy, and I'm pretty sure the ebook copy is different because I looked at the pages that were sent to me where the tables were, and they're not like that in my hard copy. It's a whole chapter difference. So I apologize for any confusion about that. Please let me know if there's any more hiccups. Please let me know. Um, And I apologize for these. I know it's frustrating. Let's see. Oh, you all should have already gotten or should be getting emails about course evaluations. And also you can access that through Blackboard. Please take the time to fill out your course evaluations. It really helps us as we are trying to make sure that what we're doing is effective and relevant and that you are gaining from it. If there are things that you like, let us know. We'll keep doing them. If there's things that you think we could change and do better, let us know and we'll do our best to take suggestions. Sometimes the suggestions are impossible. Like, I've had people say, well, this class should have, I wish this class could be 16 weeks. Well, that will never happen. As a matter of fact, we're switching there next year, it will be only 7 weeks instead of 8. So I have no idea how we're going to do that, but that's what we got to do. So, but some of your suggestions we've definitely implemented a lot of suggestions from you students and we very much value your feedback. So please take the time to fill those out. I'll give you another reminder about that too. All right. So before I open it up for other questions, let's talk about this the discussion board number 2. So you had 2 different scenarios and I kind of went through, I was kind of going through all the groups and looking, it looked like most people just went with the first one they saw, scenario A. Not a lot of people chose scenario B. Um, so let's talk about the first one that so many of you chose. This was the one with the young lady attending the music festival and she disappears and their friends find her in the bathroom. She's passed out or not exactly passed out, but she's very confused. And when they come to get her, she reacts really violently. So tell me a little bit about your all's thoughts about this one. What things would you need to explore? What would be essential things that you would need to be asking about for this patient?
Some of the things that I brought up were the concerns of if something had happened that day,
Yes.
as far as like if she'd been exposed to somebody put a drug in whatever she was drinking, or
Yeah.
she was smoking marijuana that was laced, and then also had concerns about she was found in a bathroom, an isolated area, possibly
Hmm.
another assault had taken place.
Hmm. Yeah.
So
Yeah.
so kind of things along the lines of that.
Yeah. Yeah. And those are essential things that you would need to think about. Um, so yes, she could have had something in her drink or she could have taken something, but we would need to explore the substance use aspect of it, whether she was doing it or if it was done to her. Definitely have to explore that. Um, and then, yeah, could something have happened? She's at a music festival. Maybe somebody spiked her drink. Maybe they got her off somewhere. Something really could have happened. So absolutely. Um, what other what else would you want to know about her to further expand on some of this and to try to nail down a tentative diagnosis for now?
I'd seen actually one of the better things that I saw that I didn't think of was to kind of go a little bit further into her history, see if there was any history of psychosis
Oh,
or anything like that. And
absolutely.
I thought that was a good thought that somebody came up with.
Yes, that is a good thought. That absolutely is. Uh, we know she's experienced trauma in her past. There absolutely can be psychotic symptoms with PTSD during really when PTSD symptoms are at their worst. There absolutely can be psychosis. Um, We'd probably want to know if she has any intrusive symptoms, any other, she's mentioned she's had nightmares. We'd probably want to know how often that happens, right? And also, does she have flashbacks? We want to know about that. Other things you could ask, what is another type of symptom in PTSD? We've got the intrusive symptoms. What are some of the other, what are some of the other, another group of symptoms?
Uh, I
So
think.
anxiety. Oh, sorry.
Oh
Sorry,
no, that's
Lynn.
okay.
Anxiety. What
Feeling
about
on edge, irritability.
what about avoidance symptoms? Remember what those are?
Right.
So we'd want to know if there's any of that going on. We know she has trauma, so we've really got to go down that PTSD path, right? And really assess for what symptoms in that bucket we might be looking at. And yes, hallucinations. We definitely. And so did anybody pick up on the fact that she says that she's lost time before?
Yes.
What'd y'all think about that?
Dissociating.
Mhm. Yep, dissociating. Very good. Um, did anybody think to ask about suicidal ideation?
Yes.
Good.
There's
Absolutely.
safety.
Safety and self-injury. How about that? Um, did anybody think to explore her support system?
Yes. Asking about, and maybe having to get some collateral information if she, um, you know, she can't express herself or is too anxious and can't talk about it. So many different reasons, but to talk, who her support system is, friends, family.
Mm-hmm.
Um,
Very
yeah.
good. Very, very important. Um, so what diagnoses did you all come up with?
PTSD.
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 What else did you think of that could be possibly?
I actually put differential. I put, I don't have it pulled up, but I think I put either substance abuse or cannabis use disorder.
Yeah, yeah, yes, good. That's exactly what I have, the cannabis use disorder. Um, did anybody go with any of the dissociative diagnoses?
I didn't choose that, but I know that there's a subtype, PTSD subtype, right? The dissociative types, or I can't think of
Yeah.
how it's actually worded, but
Yeah.
yeah.
Mhm.
But I chose generalized anxiety.
Yeah.
That's another very good. Hmm. It's another very good one to explore. I was wondering if
Mhm.
anybody
That's
would
what I put.
go to dissociative fugue or even dissociative identity disorder, because a lot of times when you see people losing time, a lot of people, that's where they go. Um, so I just had those down because I was curious to see if anybody went there. But yes, absolutely. Generalized anxiety disorder, you'd want to rule that out. Um, what about panic disorder? Anybody think of that one?
Yeah.
Yeah. Okay. What kind of interventions were you all thinking about that well, first of all, what how are you going to interview this young lady? She's had a really bad day. So how are you going to get the information that you're hoping to get from her? What are some of the things some techniques you can do?
Just
Um,
continuously reinforce that she's safe. She's in a safe environment, and
Yes. very
Therapeutic,
much.
therapeutic alliance, establishing trust. Ask for permission to speak with her friends if available, if
Yes,
necessary.
yes, absolutely. Um, what about the fact that when she hears male voices outside the door, she's flinching?
Yeah, that's
Anybody?
another PTSD symptom.
Hmm.
Would you maybe try to have a female
Quiet.
interview her?
Oh, yes, yes, yes.
Yeah. We don't we always have to assume trauma, and of course she has trauma. We know she has trauma, and we do not want to do anything to re-traumatize or make things worse. Um, okay. What types of interventions were you all thinking about? I know some of you probably wanted to go to medications, but that's not what I'm looking. This isn't this particular course. We didn't focus on medications, so that's why I kind of specified non-pharmacological. So, what did y'all come up with?
Trauma
So
focus,
EMDR.
CBT.
Yeah, the
CBT. What
EMDR,
else? EMDR. Yes, good.
the trauma informed care.
Trauma informed care. Yes, 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 yes. Um, and there's another one. I should have added this and I forgot. Uh, ART. What is that, Dr. Jones? I just knew it. Let's see. Accelerated resolution therapy is what it's called. That's something else that I've been seeing where I work in the community mental health center where I work. There are some therapists that do EMDR, and now there's a couple that are doing MAT, and my patients are loving it. They're loving the MAT. So, or I'm sorry, ART. Sorry, I've got something else on my brain. The ART. They really like it. So, um, but definitely those. What other interventions could you think of that would be important?
One of the things that I put was possibly involving a sane nurse. Um,
Oh, good idea. That's really good. Yeah, I like that. That's excellent. And maybe have the sane nurse come in and talk to him, like ask them if they'd be willing, but if they could come in and talk to him after we've talked to them, and we could stay there with them if they wanted that. So, but yeah, that's really good. That's a really good idea. Did anybody think about group therapy?
Yeah,
Sometimes
I
with
think that's a good idea.
sometimes with PTSD, it's good. Sometimes it goes a little bit wonky because sometimes people without meaning to, they can trigger each other by what they're talking about.
Mhm.
So, got to be a little careful with that. But a good group therapist would be able to negotiate that. And then something else, she's not sleeping, right? She has to smoke marijuana every night in order to sleep. So would we want to talk about sleep hygiene?
Yes, for
Yeah,
sure.
absolutely. College student, they don't usually have good sleep hygiene.
Mm-mm.
So we want to talk about that. So that scenario, there was a lot going on there, a lot of things that you had to really think about and consider.
I've got
So
a
I know.
question. Oh,
Oh,
I'm sorry. Go ahead, Beth.
Oh, go ahead.
we no, go ahead, please.
No, no, no. Go ahead. I don't mind.
Okay. No, thank you.
You're up, Beth.
So, and I just wanted to explore kind of any possibility. So I even went as far as to say that I would order labs, and I don't know, is that okay? Okay.
Yeah,
Okay.
yeah,
I just said, CBC, CMP, maybe get a urinalysis on her
for
for
sure.
any infection, check, see if she's dehydrated,
Uh-huh.
because of her confusion. And yeah, so I just wanted to make sure that was okay.
Oh, absolutely, absolutely.
Okay.
That's part of a good assessment.
Yeah.
And you'd probably want to check for STDs, right?
Yes, that's an awesome idea. Yeah.
Huh. Probably would need to include that. Um,
I even wanted to say that I would explore whether she had reported. I know that's kind of, um, you know, something that we've had to do on the job. So it's kind of also thinking about experience, but um, reporting the rape that had happened.
yeah, we don't
Couple,
know if she supported that or not, do we? We just know that it happened.
right.
Yeah. So
So,
that would be something to try to ask about and learn and
right.
talk about. Yeah, that's really good.
Yeah, because who knows? I mean, the guy that she saw, it looked like him, right? But could have been him.
Yeah. I mean, things happen. Things bad things happen in the world. They do, and they're
Yeah.
happening more and more. And music festivals, there's a lot of people going, a lot of people who may be altered in certain ways. There can be a lot going on. So it's a safety issue, even taking away the PTSD that she already has. It was already a safety issue, right?
Right.
Yeah, there was a lot to think about with this one. Tom, what did you want to add?
The part of the scenario where she talks about that in the past she's lost time when she either smelled things or saw things that reminded her of that night.
Hmm.
Would you consider that a flashback, even though she doesn't refer that she has the memories come back, where she
I would,
loses the time?
I would, because that episode is triggered by a smell or a sight that's an intrusive thought. So I would
Okay,
consider.
okay,
And what she's doing is she's dissociating, and it probably does trigger that memory, but then it's gone because she dissociates. She removes herself from it. So
okay. Thank you.
yeah, I had a patient a few years ago who, oh gosh, the trauma. She just had the hardest time. And she would come in and she would sit, and she wanted to work so bad. She really wanted to get better, and she tried, and she would always show up. But depending on what we started talking about, it seems she always dissociated during one of our sessions, always. And one time it was severely dissociated. She got up, she took off, she was out in the street, in the middle of the road with traffic, and I had to go bring her back. It was something I think she was talking about her mother. Her mother had done horrific things to her in her past, but it's very unsettling when it happens. Like when it happens the first time, if it's the first time you're seeing that, it's quite unsettling. So be prepared. It'll probably take you back just a little bit the first time you see that. Has anybody seen that happen before? Anybody who's on here? Have you seen any dissociation besides Dr. Jones? Nobody?
I had a friend growing up. His dad was a Vietnam vet, and
Oh,
he would have very bad flashbacks, especially when he drank. But
mhm.
I mean, he would lose time for it would go for 20 or 30 minutes.
Yeah, yeah, yeah. It PTSD can be just so incredibly debilitating, just so incredibly debilitating. Um, so and that's why I like this discussion board, because it really makes you think about a lot of other things that you have to think about in association with the PTSD and the trauma and all that. So did anybody who's on here want to work with our guy who who thinks he has ADHD? Anybody on here choose that scenario? Nobody did. I like that scenario too. Well, for that scenario, of course, the young man was using a whole lot of Adderall. We don't know where he was getting it. That's something we would have needed to find out. Um, we don't know if he's actually uh, has ADHD or not. We would definitely have to explore that, but it looked like he's really stressed out. He's a law student. He's studying all the time. Plus, he's a door dasher. He's got a job. He's not getting any sleep. He's having to drink every night to get some sleep, and so much going on with that. Oh, he smokes pot too. Um, so this was one that I really wanted you all to look at not only the mental health, the substance abuse potential diagnosis, but the fact that mental health diagnosis is tied in with it. And he really fits a lot of criteria for major depressive disorder. So if any of you who are watching, if you chose that scenario and that was one of your diagnoses, well done. There was a lot in that scenario. I wish somebody here had chose it, but I'm not going to spend a lot of time on it. Um, if anybody wants to talk to me about it, shoot me an email and I'll be happy to, I'll be happy to converse with you about it. Now, any next week's the final. It opens on Wednesday. All the materials open. The final will cover weeks 5 through 8. Just like the midterm, there'll be 50 questions. You'll have 60 minutes to take the final. There'll be multiple choice, multiple answer, just like the midterm. Okay. So, what questions do you all have about any of the material? Is anything not making sense? Is anything confusing? Anything need to be clarified? And any of it's fair game. Weeks 5, 6, 7. If you want to go all the way back, you can, but I recommend you concentrate on 5 through 8.
I have a quick question regarding schizophrenia.
Yeah.
It says that I know that the two positive symptoms or the top three that says in the DSM, but when it says 1 month, does that mean, is it like, what is the criteria? Is it every day? Is it 5 days out of the month for it to be a criteria of positive schizophrenia? I'm a little bit confused
It
about.
doesn't really clarify that. The way it reads, it's like it has to be present every day for a month because it doesn't clear most days from it doesn't even say that. So I would interpret it to say most days for a month. Because if someone is floridly psychotic, they're probably, well, depending on what's going on, but if it's schizophrenia, they're not going to get better without medication. So I don't know if that helps or not.
It does. And just one more. Could you explain a little bit more about the schizoaffective? That's kind of the
Yeah.
bipolar.
Yeah, so that diagnosis, like I said, it is so hard to diagnose because most patients that you see are not going to really have the insight that it takes to know that, yes, I did have a 2-week period of psychotic symptoms where I had no mood symptoms. They're not going to know that. They're not going to, I've never had a patient who could tell me that because that's what it has to be. There has to be the psychotic component, the active psychosis, and there has to be the mood component with the major depressive disorder and mania. So, in order to meet criteria for schizoaffective disorder, there has to be a 2-week period where there's psychotic symptoms, but no mood symptoms, no depressive symptoms, no manic symptoms, just psychotic symptoms, which makes it very, very, very difficult to diagnose. Does that make sense?
Yes, so it just so as long as they're not depressed or manic, then that would be considered the schizoaffective, but only if it's for 2 weeks, though.
Yes.
Okay.
Well, at least 2 weeks.
Okay.
They have to have at least a 2 week. They have to have psychotic symptoms without those mood symptoms, because if the psychotic symptoms and the mood symptoms are occurring at the same time, that could be major depressive disorder with psychotic symptoms. That could be bipolar disorder, manic phase with psychosis. So in order for it to be schizoaffective, there has to be the component of psychosis without the mood disorder. Does that help? Does that make sense?
A little bit. So it'd be no mania and no, what about hypomania? Would that
Either.
be
Yeah.
okay?
And no evidence of mood symptoms. So,
Okay.
and I mean, they may have them they may have them a lot, but there, in order to meet criteria for that specific diagnosis, there has to be at least a 2 week period of active psychotic symptoms, hallucinations, delusions, without mood symptoms of major depressive disorder, mania, or hypomania, which again, it makes it really hard to diagnose.
So then if it's over the 2 weeks, but then less than 1 month, then it would be that schizoforum.
S- s-
So how do you say that? That's why it's,
Schizoaffective.
yeah, the schizoforum, what's that called?
Oh, schizophreniform. Yes, yes, yes.
And that's it. So that's where the time comes in. So if it's over 2 weeks but less than a month, then it could be schizo, whatever it's called, like what you said.
That's true. Yes.
Chroniform. Okay, that's what's so confusing. Okay, thank you.
Yeah. The timing on the psychotic disorders, the timing is really important, because if you notice, schizophreniform can only be a certain time. After that, if it's longer, it turns into what?
So it'd be the schizophreniform, and then if it's over 6 months, then it's schizophrenia.
Yes, ma'am. Good. Yes. The timing of symptoms. And remember, the timing of the symptoms in, oh, that was back in week 4. So we're not talking about those, but remember how important the timing of the mood symptoms were in bipolar 1, bipolar 2, cyclothymia, all that stuff. So again, with the anxiety disorders and the psychotic disorders, the timing is really important in several of them. Couple of the anxiety disorders. How can you distinguish from acute stress disorder versus PTSD? Who knows that one?
Isn't the acute stress disorder up to 30 days?
Mm-hmm. Symptoms look the same, right? The symptoms look the same. There's the hyperarousal, the avoidance, the intrusive symptoms, nightmares, flashbacks, all that stuff. But if it's been less than 30 days, it's acute stress disorder. Or after 30 days, if it still remains, that's when you go into PTSD. So make sure you're looking at timing, because some of the questions will require that you know the right timing. Because sometimes that's one of the major distinguishers between this versus that. And so it's real important to really be nailing those down. These are good questions. What else you got? So in week 5, we had the anxiety disorders. We had generalized anxiety disorder, OCD, PTSD. There was quite a bit about that. The phobias. Let's see.
I have another question. I'm sorry. For the
Yes.
for the factitious disorders, so the
Oh,
and the imposed on others, it's the same thing. It's just either it's yourself or it's others. So is it the same thing for both of them? Okay.
Yeah, and it's what used to be called Munchausen's disease, and then Munchausen's by proxy. It used to be called those, but now it's factitious. You remember hearing that term before? Munchausen's syndrome?
Yeah, I was just curious because there was just an explanation on when it says imposed on self. I was just wondering if the imposed on another is just the same. It's just kind of to that person, all the criterias. Okay.
Yeah, it's either you who are insisting fabricating symptoms, or you're doing it to someone to make them appear sick. That makes sense?
Yes,
A lot of
thank you.
times it's a parent and a child. A lot of times if it's factitious to another person, a lot of times that's parent to a child, because it gives the parent something that they're needing, something emotional, something psychological, but that's usually where that comes from. Does that make sense?
Yeah, that makes sense. Thank you.
Good. So yeah, we talked about panic disorder. We talked about agoraphobia. Um, let's see. And then we've got, oh, what about the the pandas? What do y'all know about that? You remember the
So
pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections? That's a mouthful. I like pandas better.
did it require two diagnoses or two episodes of the strep, or can you get that with just one?
Two,
Two, okay, all right.
two. Yep. Is there a test for it? Is there a blood test for it?
Mm, other than I don't think there would be unless it was strep. I mean, if you're looking for strep, but
Yeah. Yeah, there's no blood test for pandas. Um, you want to remember the child could already have something going on, OCD. What you'd be looking for are some very sudden, very acute, very intense symptoms. Very sudden, very acute. So the child would look very different from what they usually look. So that's something to remember with this, with pandas. It's very sudden, it's very acute. It's a big change.
how common is it? Is it
I don't see kids. So, and I don't hear parents telling me about it. Dr. Jones, do you know? How?
Believe it or not, it gets missed. Um, and I've talked to a couple of our grads who have now seen it. And then I think we've mentioned that Dr. Hovermill, and I think some of you all are on them too, the PMHMP sites. And for a while there, messages were coming out quite a bit about pandas. I don't know if it was because the time of year and strep was kind of, I, I don't know, but, so it's something that is there. It's something you could encounter very easily. So it seemed to have been an influx for me because I was hearing about it and seeing, but then we went long periods that we didn't hear hardly at all about it. So I don't know if it's an awareness thing, and people are more now aware to look for that. But it's a possibility and something definitely to rule out with symptoms. Absolutely.
Um, Then there's the, sorry, I keep getting the volume on. There are the other compulsive disorders. Remember, body dysmorphic, skin excoriation, trichotillomania. Let's see, what else did we hit? Let's talk about the somatic disorders real quick. So, who knows the difference between somatic symptom disorder and illness anxiety disorder? Who can tell me the difference? How are they different?
I'll try.
Go for it.
So the somatization, you would actually they would think that they were actually feeling the symptoms of it, and then the illness anxiety, it could be they were just afraid of getting it, or
Yes.
okay,
You hit that. That is the boiled down in its most simplest form. Yes. With the somatic symptom, they are experiencing symptoms. With illness anxiety, they are anxious about becoming ill, if you think of it that way. So with somatic symptom disorder, these are the people that I've got all these problems with my stomach, I've got, or wherever, my head, wherever it is. And I just am having all these problems and nobody's finding it. Nobody is finding it, what's wrong with me. And I know things are wrong because I'm nauseated all the time and I've got all these issues. I've got heartburn. I've got all this stuff. So they're going to all kinds of providers because they just know somebody's finally going to figure out what's wrong with them. Do they want to come see a mental health provider? No, why not?
They don't want to be told that there is nothing physically wrong with them.
Exactly. It's offensive. If they do not want to hear that. They do not want to hear a recommendation to go to a psychiatrist. That's not what they're wanting to hear. With illness anxiety disorder, there could be some reason, for whatever reason, that the person has this anxiety about getting this some kind of specific illness, and there's no firm basis for their fear. There's nothing to corroborate that. There are no tests that have been, there's just nothing. But they are afraid that they're going to get something. Maybe their parent had a form of cancer, and maybe they are consumed with, I'm afraid I'm going to get this. I'm afraid I'm going to get this. I'm afraid I'm going to get this. But they are consumed with getting sick, and they will spend a lot of time researching the disorders and coming up with theories about treatment if they ever need treatment, but they don't actually have symptoms. Or if they do, it's something really mild, like they might have had a cold or they might have had a headache. Something really mild. Does that make sense? Does that help? I also gave you a little video to watch that I thought helped kind of distinguish between the two of those. That seems to be something that students in the past have struggled with, the distinguishing those. But I'm hoping that with the little video, made it even more clear. We talked about PTSD. We talked about acute stress. We've had some questions about the psychotic disorders. Any questions for Dr. Jones while you've got her on here about the childhood disorders? Good with those? And then in week 8, we've got a few different things going on. We've got the neurocognitive disorders, which, like I said in the intro video, I'm pretty sure probably all of you have had that content before in some shape or form. Might have been a long time ago. Now we're looking at it through a little different lens, but these are the dementias, Alzheimer's, Lewy body dementia, vascular dementia, all of the different neurocognitive um, disorders. And then also the eating, feeding, and elimination disorders, which those of you who see kids, you'll see a lot of those. Uh, you would probably see more of the elimination type disorders in kids, although there could be adults who are developmentally delayed or have other issues that you could see some of that in them as well. But the eating disorders, again, I'm sure that all of you have had content about anorexia nervosa, bulimia, binge eating disorder. Again, this is just looking at it from a different lens, from the PMHMP lens, and through the diagnostic criteria. So hopefully all that is going to be more of a review and just a little different perspective than learning a lot of new stuff. So everybody feel okay about it? Any other questions? You can email me. All right, let me turn it over to Dr. Jones. We're losing, I lost track of time.
We've
Thank
had this,
you.
no problem, Beth. We've had this conversation though, Professor Hume. Clinical's old news. so, um, we're plugging along. Christy continues to work on summer request forms. I continue to work on summer requests. Again, can't reiterate enough. If you're having trouble, please reach out because I'm in full mode of looking for people for summer. Remember, we don't have any break, and I hate to say that, between spring and summer. So that means we've got to hit the ground running for those 8 weeks. So we don't want any delays there on getting started. So make sure you reach out for summer, but I know she's working on getting things out and getting contracts sent out or looking at request forms. As a reminder, it's so important to take that I know Professor Hume puts something about self-care out all the time in her announcements, and self-care is critical. You will hear us talk about it the whole program. And I think some of your preceptors talk about it as well, maybe with you or talking about the self-care ways they take care of themselves. So spring break is self-care week. As a reminder, there is no clinical activity during spring break. So I'll put it in an announcement as well. So if you attend the week prior to spring break, normally your typhon notes would be due on the Friday of spring break. So I will extend that deadline another week. Those will not be due because then you won't have any notes for the week of spring break. So technically, to give a number there, I looked at it. Do you think that could have stayed in my head? No. When you work the clinic, this is the kind of head you got. You got all that circulating in your head. So they would be due the 28th of March. Now, if you don't want to get behind, you're more than welcome to put them into type, and that's fine. So that's off your plate. But just so everyone knows, there will be an extension on that deadline. Because I truly want you all to take time for yourselves, time to be around friends and family, and do something really good for yourselves. So that we can finish strong these final 8 weeks with Dr. France and Psychopharm. So again, no clinical activity March 17th through the 23rd. So St. Patrick's Day on. Everybody wears something green so you don't get pinched. So case simulations are coming after we get back, where you will have from March 31st to April 6th. So if your facilitator has not already started talking about those, be aware that they probably will be very soon. Because I think we all plan on getting those getting scheduled if they're not already scheduled prior to leaving for spring break, prior to that week off. So I will talk more about that the week we get back. But you will interview your facilitator as if they are a new patient. So, and you'll do a full initial eval. So you are allowed to have things in front of you. You can have books in front of you or resources in front of you. But we always make the statement that you can't do this the whole time and read from a piece of paper. You have to have engagement with your facilitator as they are the client. So you will be told when you come on screen with them a little bit about the client you're about to see, because oftentimes that's all we get is a little tidbit about who you're about to see. To be honest, I get in student health now, I get no tidbits. They just arrive. Maybe I have an idea that they're coming in for anxiety or depression, but that's the extent of what I know. In some cases, they are seeing some therapy resources at the college, but oftentimes, even if that's happening, I don't always get a lot of information about what's going on. So what happens in real life. So that's coming up. Very exciting. That's fun times. And which means because we have another assignment, that means demographic only weeks are coming. Those are always exciting. So the week before K-Sims is a demographic week, but I'll also put an announcement to that effect. So. All right. Any questions about clinical?
Hi, I apologize for this question because I'm sure it's in the syllabus. But so this week tomorrow will be my third day at clinical. And so do I still do 6 notes or is it going to be 9 if I'm doing 3 days?
Beth, email me and we'll chat.
Okay.
About the number of hours or about the number of notes. So that's kind of out of the norm. So just email me.
Thank you.
Sure.
Okay.
And as a reminder, hang on, Dylan, I see you. I also, for some reason, Beth triggered that you all are scheduling them great. But as a reminder, I want to try to get midterm calls done if we can't. We're going to do some after spring break, but just reach out to me to start working on a date and time to even get that on the books, even for the week after spring break. So make sure you're doing that. Okay, Dylan, hit it.
So sorry, I'm really late, so just let me know if you guys already went over this because I'm gonna watch the first part anyways,
Okay.
So no need to repeat yourself if you already
Okay.
explained it. But I'm
Gotcha.
having a really hard time really understanding differential diagnoses, like
Okay.
just concept in general. So my question is, when you have an initial evaluation, do you always have to have a list of differentials? Like for example, if in your assessment and your data section, or like if you're going through your whole data section and it's very clear, like you already ruled out all the things you're thinking of in your head, right? So obviously you have differentials in your head when they first come in and they tell you their chief complaint. You're like already starting to think of potential differentials. And then you're through and it's kind of adding more to that. But I guess like in my example of my initial eval, it was very clear that I went through the diagnostic criteria of all the differentials with the patient. And so it was, or my PMH impedance. So we were able to rule out all of the differentials that we were considering and then made a diagnosis based off that. So it was like, I understand sometimes you won't have complete information and you'll need to send them out. And at that point you would maybe have differentials, but do you always have to have differentials? And when you're writing your note, do you have to start by writing all the different, even if you, I guess I'm just really confused about what even.
Well, and I think you're asking a great question. No, you're asking a great question because, but in most cases, Dylan, there is some things that make you tilt your head, and you're like, like I mentioned, my college kids coming away to college for the first time that have been very close to their family. I had one that came in and was really struggling with some mood symptoms. But it all circulated around going away to college and being away from home and family, and so it was like an adjustment disorder. So, but with that being said, some of her anxiety, even though it was adjustment disorder with, with anxious and depressed mood, I could put those there. My differential for her was, well, okay, we're so focused, she's so hyper focused on being away from home and all this, but is there actually some underlying anxiety that goes farther than that? Does she have either some GAD or so it's sometimes you're just like, okay, is there more to the story? And so I mean, if even you get kind of a tidbit. I had one today. I had a new person today. And I got a tidbit, and she didn't meet criteria for PTSD, but she's had her parents have a very toxic relationship and to each other, which feeds into her. And so, so there was and that was causing some of her mood symptoms. So oftentimes it might not be I think we get so wrapped up into, labels. And believe me, clients want that label too. They want to know what they have. But it's more to kind of critically think, what am I seeing here? What is there more to this picture than what they're showing me? Are they, because they sometimes don't disclose the whole time. So it's more that you're looking for other things. And it's not that they're going to ever, like I said, it's either rule in or rule out even. It's just like, okay, how do I rule in? Is medical. I mean, technically, is this, and we're going to talk a whole lot more about this in the summer too, but is there more medical stuff? Is there a thyroid issue? Is there substance use issue? All of a sudden, on a second visit, I get told, oh, by the way, I'm using marijuana every day. That was not disclosed the first time. And so it's just more of making sure that we're seeing a whole picture.
So I guess when you're writing up an initial eval, should you always list differentials?
I do.
Okay. Okay.
Yeah.
And that's just to show essentially that like you're thinking critically, you're thinking of all the possible things this could be, but you can still make a diagnosis.
Oh yeah. Oh yeah.
And does it have to be a provisional diagnosis, or is the provisional only if you need more information? Like if you have all the information, they clearly meet DSM-5 criteria, then you can just give them that diagnosis, right? Like it doesn't have to be provisional. But if there's missing information and you're like, I'm not sure, we need to like I'm thinking like for
time frames seem to hit that problem. If they don't give you a good time frame that meets the criteria for some, and we just talked about time frames on many of the disorders, but a lot of time, especially generalized anxiety, if they can't tell me it's been that long, if it's only been, a few weeks, then that's not full criteria for GAD. Even if they tell me excessive worry about everything, muscle tension, irritability, issues with concentration, all those other aspects, but it's a time frame sometimes that I have to go with an unspecified anxiety.
Gotcha. So you would go unspecified provisional, and you would say like provisional.
I don't even use the word provisional. I just say an unspecified, especially if they're hitting all the other ones and it's just a time frame. It's at that point unspecified anxiety until we hit that time frame.
Okay, and then there's specific. Yeah, I think so. And then there's specific diagnoses like the premenstrual dysphoric disorder, where like I was reading my DSM-5 about it, where it says like you actually have to make it a provisional and have to have them chart their mood symptoms over, I can't remember how long it was off the top of my head, but in order for it to be confirmed, like you cannot give a diagnosis of just premenstrual dysphoric disorder on a first visit. It has to be that follow-up.
Correct.
Okay.
Yes. But it's like, and I hate to put it this way, but it's looking like the duck and it's quacking like the duck, but we can't do it. And like it says, we have to wait that long because you'll hear it a lot. Hormones are great.
We love them.
Love them.
When you're listing your differentials, is it best in an initial eval to list out like diagnoses, like differential diagnoses, and then at the bottom then, and like would your So sorry. So, okay, if you're looking at, let's say, generalized anxiety disorder, and you're pretty sure it's generalized anxiety disorder, but your differentials are like whatever, OCD, social anxiety, PTSD, right? So you have those three. I'm just giving an example.
Right.
You have four differentials, and generalized anxiety would be considered one of those. And then beneath it, can you say, like, but I'm giving a primary diagnosis of generalized anxiety disorder because they meet this criteria?
Correct.
Okay.
Correct.
And then they may also have those other ones, but at this point, you're just calling them differentials
Correct.
until you have more information and follow-up visits. So you wouldn't even give the differentials as an actual diagnosis. They would just be a differential until confirmed later on. So you're not going to just give a provisional, like, oh, it might be, I don't know, but it's
Right.
like not. Okay.
And the only one you're going to bill for is the ones you tentatively are saying, that you are saying this is what's happening and they meet criteria. But these are the ones that are still on the table to consider.
Okay.
That we're
And
watching.
then to complicate things further, sorry, I've been really confused about this. I've been reading, so I'm trying to take up so much time. But when you're adding in the primary and secondary,
Mhm.
can you have more than one primary? Like if they come in and they clearly are both depressed and like they have generalized anxiety and MDD
Mhm.
concurrent, or they
Mhm.
have so you can have two primary.
Mhm.
Okay, if
Yep.
you're majority of the time. Because sometimes I have a
Yes.
hard time because I'm like, well, all of these things are equally impacting the patient, but primary
Mhm.
really you're talking about what is causing the most distress to the patient, right? And then
Mhm.
secondary is like, okay, there's these other things. They also have insomnia, they also have PTSD or whatever, but it doesn't seem to be impacting them as much right now.
Correct.
Okay.
I always call it what's driving the bus. And depression and anxiety love to drive together. They like to be hand in hand on the bus, causing all sorts of havoc. But
Okay.
it's not always a guarantee, but I kind of think of it as, and I used to always call it that way. Who's driving the bus?
And so there's no limit to the number of primary diagnoses you could have or secondary.
Well, in the billing world, there's four.
Okay.
So in the
Four.
wonderful billing world, so it's only up to four. So, so yeah.
Okay, I think this clarifies to some degree. You don't necessarily, you should always have differentials.
Mhm.
So always,
Something you're kind of considering, and even it can be just one that we're considering if it's a pretty simple. We don't have the luxury of having too many of them, but sometimes it is pretty cut and dry, and it seems that way. But for the most part, there's usually at least something, if not one or two things that you're like, So, mhm.
and you can add on differentials later on, like in a follow-up visit, if something
Yes, oh yeah,
like, okay, maybe this is playing a piece, like you're like, oh, I didn't think this was a personality disorder before, but now that I'm getting to know this patient, seems like it might be partially. So I'm gonna just add that as a differential for
right.
now and then continue to
Right.
watch. And
I
that's
am very cautious to do any personality disorder immediately. It's a differential. If they're meeting somewhat of the criteria, I wait on the personality disorders until I know them a little better.
okay.
They
So
usually disclose more as well.
okay. Okay.
Mhm.
So the purpose of differentials is just to be considering all the options. You
Yep.
can, in a initial eval, have the same thing listed both as a differential and then as a diagnosis. Like you could have differentials, generalized anxiety disorder, OCD, blah, 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 and then
Well,
primary.
you wouldn't have to be redundant. If you're going to go with like GAD, you don't have to put it as a differential.
Okay, got it. So the differentials are like things
The
other
ones that are not,
could
yes, that are not
if you're
tentative.
pretty confident it's this,
Yes.
they meet all the criteria, just put it down as a diagnosis.
You got it.
Okay. That clarifies so much. I've been
You're
really
good.
confused. Thank you.
Well, and if things continue to come up, we can continue to chat about it.
Perfect. Thank you so much. I appreciate it.
Sure. Anytime. Professor Hume, there was a question in the chat about the test.
I'm getting to it. I'm getting to it.
Okay.
Any other questions for me? I have one question for you that I meant to ask. So the past few, especially weeks 4 through 8, there's a lot of videos that I've given you that are optional, but for each week, just to kind of give further illustration or examples of things. Is anybody watching any of those? Do you like them? Do you find them helpful at all?
I do. I really like the YouTube videos.
Good.
Yeah, I like the Jeopardy too.
Good.
I do appreciate that. Thank you.
Good. I enjoyed putting the Jeopardies together. Yeah, and as I've tried to make clear, all of those videos, most of them are optional. There's only 3 or 4, I think, that I really needed you to watch, but they were all optional. But they were ones that I had found that I thought really did a good job of illustrating or bringing to life a particular diagnosis or a concept. The one little cartoon about the illness, anxiety versus somatic symptom, just fun little things to help you all remember things. So I just wanted to ask if y'all had been, if anybody had time to look at them. So thanks for that feedback. Bryant, the test will cover weeks 5 through 8. Week 5, week 6, week 7, week 8. That's the weeks that are on the test, on the final. So there won't be any questions from chapters 1 through 4. Or weeks 1 through 4.
And excuse me, I have a question for.
Yeah, Caroline. You just muted yourself though.
I always do that. I always.
There you go.
For the evaluations, because I'm getting, I think I might be getting mixed up for like the course evaluations, and then with we also have do we need to be having the clinical evaluation from our preceptors? Is that
yes? Professor Hume when she talks about course evaluation, you're going to get a course evaluation about 880. You're going to get an email through EKU that says, please mine won't come out to the end of the semester, but because I'm 16 weeks, but you'll get, but yes. And then on my course, 800, your your preceptor will complete that 4-page midterm evaluation that's in week 8.
Okay, so we just need to send that to our preceptor, right?
And we do that midterm call. We do 1 call a semester.
Okay, so just go ahead and send that to our preceptor.
Absolutely.
Okay.
She's aware. She knows. She remembers them.
Okay.
They're hard to forget.
All right, folks. This is our Dylan. Did you have something?
I'm just wondering if Dr. Jones has like 2 or 3 minutes to stay on after this. I just have a couple really quick clinical questions for her about summer clinicals that are very specific to my situation.
So this is the last Zoom we'll have for NSC 880. So I want to tell you I've enjoyed working with you all, getting to know you, the ones that I've gotten to know your faces some this semester, and we'll be seeing more of each other as time marches on. But as always, if you have any questions, email me. I'll be sending out an announcement on Sunday, just like I always do. But if you have any questions, email me. If any other glitches come up, make sure you let me know, and I'll work as fast as I can to get them taken care of. But and then remember what we always say with these exams: don't overthink them. Don't overthink the questions. Don't add to it. Don't try to add what if. Well, what if this were? What if it was? What if this was part of it? No, what you have is what you have. The information that you have is the information that you have. Use that and only that information to answer your question. Make sure you know what the question's asking. Read your question, read it again. Make sure you know what it's asking. But don't second guess, don't what if. And while you have the ability to go back and backtrack, do that with caution. I'll just caution you about that. I talked to my undergrad students yesterday, and they recently had an exam, and several of them told me that if they hadn't have changed some answers, gone back and changed some answers, they would have gotten those answers right. So, and that's usually the case. Research has shown that. So just wanted to remind you all the tips. So I hope you have a peaceful rest of your week, a good weekend.
Thank you, Dr. Hume.
You're very welcome, everybody. Have a good night and a good weekend, and rest your brains and all that stuff.
Right.
Right.
Good night,
Thank you.
all.
Good night.
Thank you.
you.
Hang on just a minute. There we go.